Afternoon, everybody. Thank you for joining us in your lunch break. We have got a good number of people registered for this webinar on MLS Laser and the treatment of wounds. We are down a presenter today, but we've got Adam Smith with us. So Adam has saved the day. So Adam is going to tell us a bit more about how he uses MLS Laser to treat various different types of wounds in his clinic. Feel free to pop questions in the chat box as we're going through. I also think it's easier to write a question down when it's in your head rather than trying to save it for the end, and I can always put those questions to Adam. Likewise, if you want me to ask the question for you, I'll read it out, or at the end, feel free to jump in and ask the question yourself. So Adam, I will pass over to you. I know that you're always very good at introducing yourself, so I'll let you do that for you because you'll make a better job of it than me. So I'll let you carry on.
All right. Now, can everyone see that? Perfect. Okay. So I'm going to kind of cover a few bases here. We've done a bit of an audit in our clinic using the laser and wound healing, but just going to cover myself first. So I am a podiatrist. I graduated in 2009 from Queen Margaret, just outside Edinburgh. I've worked in the NHS in the past, community acute. I've started my own clinic, and I'm a member of council for the Royal College of Podiatry. Now, our clinic, we've used laser for, it says 3+ years. It's actually quite a bit over that. I was looking at that the other day, Kirsten. We got our laser in, I think it was 2019. We were right after Kirsten. She kind of recommended it. Since then, we've added the Charlie head and the robots, the full M6. So we have done a bit of a nail surgery audit. Part of the background to this is quite simply, the nail surgery guidelines changed a couple of times with the Royal College, and I wanted to just have a look and see what was going on. So we've just updated ours based on what's going on, and I just wanted to double check and see what changes are. As a part of that, I've just collated the data just for a bit of an audit to see how the lasers improved and changed it, just to present to you guys here today. What we classed as a successful outcome was the patient satisfaction, pain-free, no regrowth, and the healing time. When looking at the laser, the main things that I'm going to talk to you about today are regrowth and time to heal, because I think that's the most pertinent for yourselves in practice. So what we started off with is I had a look at 2020 and taken 21 patients from our nail surgeries that year. All of the patients were people we hadn't used laser on. So the average time for us to get them to that point of feeling that they were suitably healed for discharge was about 6 weeks. 6 weeks rounded to the closest week. Over the next period, I looked at 2021 and 2022, we had 107 patients who were eligible from all the nail surgeries that we performed over those 2 years. By eligible, I excluded anyone under 18 because we don't use laser on anyone under 18 in our clinic. I think 16 is the recommendation, but we just went for 18 in general. The patients had to be in a low or moderate risk category and not be compromised with wound healing. That means anyone who has something such as rheumatoid arthritis and is taking methotrexate, or if they were high-risk diabetic, prone to wounds or injuries, quite compromised circulation. So we only looked at low and moderate risks. We removed anyone from the data who required antibiotics, or we made a note that they weren't following the dressing advice. Some of those were quite funny, such as I've been bathing it in bleach, I've been bathing my toe in salt water, but it was, what's those crystals, the terribly horrible salty crystal things. But yeah, basically, if they were screwing it up, we had just admitted them. And then we had a look at the time for discharge and regrowth. All of the nail surgery candidates had to have had Scandiness 3% plain instead of using a different LA. Not that I think that it changes the healing outcome for that, but I just wanted to be as kind of close as I can on it. In our clinic, we use reusable instruments. We've got an autoclave, and the instruments were the same, although very sterile and clean in between, but yes, very much the same. All of the patients who were picked had to have had EZ swabs. The reason is they are, I think, the only phenol swab on the UK market at the minute, which is class 2 regulated. So we made sure that that was our choice for that, and we swabbed for 4 minutes with phenol. Every patient post-surgery gets the same dress, and we've done this for years. There's a silicone layer to prevent adhesion from the bleeding, a melilite and calcistat sandwich. That means a melilite or a similar low adherent dressing with 2 calcistat or other form of alginate dressings in between. Tube gauze over the top, and some Meafix to hold it all in place. We always remove the dressing within 5 days. Generally 3 days is about the average, but if there's weekends and things, that tends to get popped back. Dressing 2 happens after 2 weeks usually of the first dressing change, and dressing 3 a further 2 weeks later. So most of the patients will have been in at least 3 contact points after the surgery. So this is how we kind of use the laser around the toe. So what we do is we keep the laser off the wound if required. Generally not too bad, I think, to try and keep it clear. Oh, I pressed the button there. There we go. Something such as cling film over the top, if you do want to be a little bit closer to the wound, is perfectly fine, but I prefer just hovering it just slightly over the wound area, about 1 centimetre, 2 centimetres off it. We always set the settings to about 10 centimetres. The reason for that is you've got to go around the wound edges. It's ASA and Celtic both say that you've got to kind of use the laser on the areas around as well, just to get that proper kind of activation of the cells and just encourage that wound healing, as well as some vasodilation. So what we do is we use it just around, and as you can see on the model here, we've used it just below. I would probably go down to the sort of phalanx joint just there as shown, just to ensure that you're getting enough fusion, particularly around where the nail matrix has been. The settings are on the left hand of your screen. I'm not sure if you'll be able to see them, but if you're using the handpiece, it's 1500 hertz for 48 seconds. That's just a presetting. I'm very happy with the presettings on that. We've had really good results. The bottom screen is using our robotic head. It's very similar for the Charlie head. I think it's pretty much identical, actually, still the same. 1500 hertz, 1 minute 36, 100% intensity, and we just don't let the robot head move. It just sits over. So both will be set to, whether it's the Charlie head or the handpiece, to 10 centimeters. If you're using the M6 robot head, we just put it to 0 and 0 in the XY axis, so it doesn't move and it just stays directly over the toe, because the head over the area will give a good enough kind of coverage to everywhere that you're needing. Before we do any laser, what we done was, when the patient returned, we would soak off the dressing. We would cleanse the area with Effigerm or Clinisept. We tend to use Effigerm because it is class 2, again, class 2 medical regulated, while Clinisept isn't to be used on wounds. Effigerm, if we do have an active wound, we can use that. It's more or less the same hydrochlorous. A small number of patients had very wet toes after surgery. Again, that can happen, just time of the year in Scotland. It can rain at any moment, or people can not look after it as well as they should. So some patients got alpha silver. It was almost identical throughout the groups. We'll come through the group stage later on, but there wasn't enough there that I felt we had to exclude that small number of patients from the study. Dressing similar to Mepore, just a low adherent dressing. I prefer the ones like Mepore, which have a bit of tape around it, so I don't have to mess on cutting things myself. It just goes straight over. It's nice and simple. That gets changed every 2 days. The reason it's changed every 2 days, if you've not read the nail surgery guidelines, is it allows the skin to heal better. If you're taking something off every day, you're doing about 3 to 6 hours of damage every time you remove a dressing. So leaving it in place is good. If required, a dressing such as Inidine, Actolite Honey was used on the wound bed as well, just to ensure that the wound was kept nice and clean. One of the things with the lasers, we don't really want to use it over an infected area. I'm sure you can. I know I have before. I've never had any real adverse results, but it's one of the guidelines. So we do tend to follow that where possible. So reducing infections is pretty much a priority, to be honest, in my opinion. Most patients tended the 3 times following the surgery, as I stated earlier. Okay. So Group 1 was the group which had no laser at all. We had 16 participants in it. As I said, we did have a little exclusion criteria as we were going. So 5 people were removed from the group, either because they were doing something ridiculous with the wound and cleaning it with a sponge or something and rubbing it to bits, or they were bathing it wrong, or there was a problem there. But some of them just ended up with an infection that required antibiotics. Again, just when it gets that bad, I didn't want to sort of skew the data by including people who had quite a severe infection requiring antibiotics, so they were removed. Group 2 even, that's nice to count, Adam. They had 1 appointment out of their 3 with laser. There was 26 participants, 3 were removed. Group 3 had 2 appointments with laser out of the 3, 31 participants, the largest group, 3 people were removed from that. Group 4 had 3 full appointments with laser, 24 participants, 4 removed. And there was a little unlucky group who required more than 3 appointments. They had 4 plus with laser. Generally, they were either higher, sort of slower wound healers, or a couple who, although we couldn't say that they totally not followed their dressing advice, it seemed they hadn't followed their dressing advice. Again, rather than exclude them, I kept them in. So the median age was pretty similar for them all. The youngest group was group 2. They had a median age of 37. They had a slightly longer healing and discharge time of 5 weeks compared to groups 3 and 4, and even group 5, which was all 4 weeks. As you can see, the group 1, which had no laser at all during any of their appointments, was a 6-week time to heal and discharge. So by the end of the study, you can see we've managed to get down the healing and discharge time from 6 weeks to 4 weeks, which is not a bad little amount of time. So saving about 2 weeks. When we come on to the graph here, you'll see the number of participants. Groups 2, 3, and 4 did have larger numbers. The discharge time was, as you've seen on the last slide, pretty much the same throughout most of the groups. Groups 3, 4, and 5 were all the same. Group 1 was definitely longer, that extra 2 weeks. Group 2, although it was just 1 treatment of laser, most of them didn't get the laser at the first dressing appointment. That's what I tended to notice. So I'm wondering if that's what's slowing it down, and that's what means that they've taken that extra week than groups 3, 4, and 5. Again, that's something for a later study. The reason was, it was usually, when I was reading the notes, it was either too mucky after the dressing that people felt, I'm not going to use the laser, it just looks a bit too wet on this appointment. So they never had laser at the first appointment, but would tend to have it at their next follow-up, and then discharged after that, hopefully. The longest healing time was the first group, which basically was no laser. There was a couple of people taking up to 8 weeks to heal. Again, as I said, we didn't exclude anyone from this due to conditions such as diabetes, any vascular complications, etc. I just want to throw everything in there. It is a limitation of the study. It is something we could have excluded, but I was quite happy just to compare and contrast as much as we can. Out of the 107 nail surgeries in total, I know we've got some exclusion, I've not included them, we only had one regrowth across the whole 107. That was in group 3. It was partial regrowth, it was very little. Luckily, it wasn't one of my patients. Still 14 years, not a single regrowth. That's a record to be proud of. I'm happy with that. And the average number of appointments across all the groups, that's the little white bar at the bottom. So group 5, taking 4 appointments. As I say, there was just a few people in group 5 which were slightly more compromised just for various reasons. So some of them did need an extra little eye on just to make sure there wasn't any problems with them developing an issue. So they all tended to be discharged on average around about appointment 4. That's the median rather than the mean. Groups 2, 3, and 4 were all discharged after 3 appointments on the median. Group 1, if we actually use the mean instead of the median, it's 3.5 appointments. So just taking that little bit longer without using the laser. So we have been able to reduce the appointment time, certainly from groups 2, 3, and 4, where there's a bit less higher risk in ongoings with compared to group 5. When we have a look at it this way, this is just how many weeks it taken to discharge. So group 1, no laser. Group 2, 1 appointment with laser. Groups 3, 4, and 5, at least 2 sessions of laser. So group 3 was 2 sessions, group 4, 3 sessions, group 5, 4+. So as you can see, we've managed to cut from group 1 to 4, 5, and 3 down to about 2 weeks off the healing time, which is, for private practice, quite a nice thing, quite a noticeable change. So conclusions after this. After at least 1 session of laser, it appears that the discharge healing rate is should be decreased then. So yeah, basically the healing rate is improved and people are discharged sooner. We're able to discharge patients about 2 weeks sooner than if compared to the pilot study or even group 1. Slightly higher rate of nail regrowth. It's not that I want to put that in there because it's only 1, but I did put it in anyway. Just one of these things, it does happen. Might have just been a lot of phenol, could have been somebody didn't react very well. I did have a look at the photos, it was just tiny innocuous spicule, but it still counts as a regrowth. So from a private practice point of view, my findings from this are we've been able to reduce our nail surgeries by about 2 weeks, and in general about half an appointment on average, which, okay, it's half an appointment, but it's fine. Means you're using less dressings, there's less contact time, saves you a bit of time. If you're somebody who's got employees, it saves you having to pay some wages and salaries for appointments following up. So all in all, there's a bit of a cost benefit there. We did have a look at patient satisfaction. Generally across the board, everyone's pretty satisfied. There's no real deviation in it. That's why I've not went into it. 1 or 2 people saying, oh, you know what it's like, oh, there's a bit too much of the nail layer, etc. But that can happen, but generally almost universal approval of what they're happy with. There's a higher percentage in group 4, higher percentage of patients in group with no laser appointments required than 4 or more appointments. So effectively, although it taken a bit longer to get some patients over the line, they still heal within that sort of 4 weeks compared to the 6 weeks, which was promising, very good, promising. My next little part here, just something different. Some of you will have seen this before, and I'm very sorry if you have. It's a little study about a wound, okay? So the reason I like this one is my favorite wound. Although we use the laser on pretty much every wound we see now, it's this was horrific. So it's a really nice one for me to kind of go through. When the patient presented, it's a 38-year-old female with no medical conditions, a very active person, goes to the gym and works out at home in their own gym for about 3 or 4 hours a day. This still goes on. They damaged their foot about 2 years before coming to us and had some neuropathy down the lateral aspect of their foot. This had been linked potentially to some sciatica issues and just some general pain that was going on. On holiday, they decided to pick a loose bit of skin. It bled a bit, then decided to go to the pool, the beach, the gym, the bar, everywhere that you can imagine that you'd probably want to avoid to pick up an infection. Sadly, they picked up an infection and developed a wound. When they came to me for an examination, there was absolutely no sensory response on the lateral side of the foot, all the way from the tip of the fifth toe to the malleoli. We tried monofilaments, we tried touching it, I couldn't elicit a deep pain response at the Achilles, which was fine, but there was just next to no hot cold sensation, nothing. So proper neuropathy around that area. They came to us after about 4 to 6 weeks of seeing the practice nurse. They're still not quite sure how long it'd been, but it'd been about 4 or 6 weeks of seeing the practice nurse. The GP had been given some Fluclox 250 milligrams, which had ran out before visiting us. The dressing they'd had put on was just a piece of gauze and a bit of tape. There was no offloading, no support, no other onward furrows, nothing else had been done. It was just, here's a bit of gauze, here's some antibiotics, good luck. So that was the presentation the night before she came into us. The pain was about 6 out of 10, which, when you've done all the neuropathy checks as I had done, was a bit concerning. Suddenly you start thinking anything such as osteomyelitis, possibly tendon degradation or anything. Luckily, they managed to avoid everything like that, but it did cross my mind. We had some heavy soiling on any dressings or socks. Gait was compromised. Patient hadn't been told to take any exercise limitations. Still attending the gym sort of 3-4 hours a day. On appointment 1, I was able to probe the bone. It was pungent, shall we say, very odorous. Heavy callus all surrounding the area. There was a lot of slough overlying and the dress was heavily soiled. After about 3 weeks and 3 appointments, we managed to get it down quite significantly. Still a bit sloughy, still a bit not brilliant to see, but we'd managed to get the wound under control quite significantly. So what we done was we used the acute scan phase and the wound healing preset. At this point, I didn't have a Charlie head, and I do love my Charlie head, but the handpiece is actually quite super for wounds. Part of the reason is, as I say, you can go around the wound edge quite confidently, knowing that you're kind of catching everywhere. That's the wrong slide. Never mind, that's for later. I've obviously put it in the wrong place. After about 8 weeks, we were just using dressing, so we managed to get the wound pretty much cleared up. Got a lot of the slough away. It wasn't closing. We'd done orthotic therapy, I'd offloaded it, we'd used dressings, we'd used a variation of wounds. It was just not really wanting to shift any further close. So after about 8 weeks, we got it to there. For the next few weeks, we kind of managed it until we got a laser. Now, one of the first things that we got told on our laser training is, hey, you can use this for wounds. Phoned up the patient, they came in, and we started trying this. So as you can see, that's after 3 weeks of the laser. Just going to go back. You can see the wound has basically fallen. I would say about 2/3 in size. Still a little bit of granulation around the edge, but it looks much healthier at that point. The skin was in a good condition. It had actually healed from the base really quite nicely. So after using the laser for 6 weeks, we'd went from this stuck, stubborn wound, which hadn't moved, hadn't done anything, to literally healed over. Now, a little bit of scar tissue over the area, but by this point, she'd been about 4 or 5 months since the initial injury. And there was a prolonged period of nothing really being done to try and offload and help. So you can see we managed to get the wound closed within that sort of 6 weeks of using the laser. Although there's little breakdowns because they still ran and still do everything, you can see the wound there looking very good by the February. I think we started in the October, so it was looking good. By the March, small breakdown, just excessive exercise over the area, but nothing to write home about, no actual open wound. And this is the patient side by side, sort of 6 and 8 months, no breakdown through August 2020 and October 2020. So you can see really the improvement from that very first open wound, which you could have went very seriously bad. And this is actually the appointment on the 14th, which was last week. So you can see the wound actually still a bit of scar tissue. They're never going to get rid of that at this point. I'm pretty sure it's been there for so long, but it looks so good. They're having no pain and issues because we've been using the laser for neuropathy and neuralgia, which was the slide that I put back there. And we've been able to get a little bit of feeling down that lateral border. So we've been able to do some work to improve her gait as well, which is fundamental in offloading this area and making sure there's no problems. So we've been able to use our foot gait scan. We got some insoles 3D printed from her. We've also used this memory foam and custom carbon fiber insoles, just to ensure that they've got something that fits all their shoes. She really likes her 3D more for her weights and gym training, just that little bit of sponge. The custom are more suited for going out and about. So we've also moved on to a daily moisturizer. We've picked Restorate. It's quite a highly absorbent. It's also high urea content, and we get her back in very frequently just to make sure the area's maintained. This is a little bit of how we would use the neuropathy setting, although it would be the other side of the ankle for the lateral, but basically moving up the sort of perineal nerve down that lateral border, using the brachial neuralgia setting. You can use the sciatic, but I like the brachial neuralgia presetting. That is my favorite setting on the device. I would say using it for about 6 minutes per area such as this. So I would do just below the lateral malleoli, above the lateral malleoli, and just around about halfway up between the knee and the malleoli. That's on the nerve line. So that really does help. We've also been using the laser just to improve the skin integrity and keep her kind of comfortable and well maintained. If you've got any questions, there's some of my details there. I think I'm going to stick around and Kirsten will ask if there's anything. So if there is anything that you want to ask me, just ask me when Kirsten sort of says. But apart from that, thank you very much.
Perfect, Adam. Thank you. I'm just going to check in now and see if anybody does have any questions at this point for you about that presentation and the cases that you shared there. And if we don't have any questions, then I will move on to Rich. Has got his hand up. Fire away, Rich.
Sorry. Adam, nice to meet you, pal. Brief question. Before you started using the laser treatment, how optimistic were you about getting to that end result?
See when it was quite stagnant, not at all. I wasn't very thrilled. At that point, we did try some different dressings, such as, not sure how familiar you are with dressings, but things like Prontazan to try and clean it. There's a really good one, Promogram Prisma. It layers up and starts healing the skin in. We tried all sorts. As soon as I got the wound bed clear, the main thing is clearing the infection, which, you know, is part of what the main thing with cleansing the wound is. Keep that clear, and then it was just a case of using whatever dressings I could kind of put in it, offloading, because was it, every 30 minutes of direct pressure, you can do up to 4 to 6 hours of damage depending on your weight and activity.
Wow.
So you're trying to keep that pressure off and try and prevent the wound from just becoming damaged again. So I wasn't confident when we got around about 3-4 weeks down, and it literally hadn't moved an inch. And Promogran Prisma for a tiny little dressing is about 40 quid, and we chuck plenty of them at it. And I thought, if this is not shifting it, it's going to be a case of going in and possibly a skin graft. So actually I'd started contacting dermatology to have a chat about these kind of things. Wrong time with COVID going on to actually try and do anything like that, but I did feel it was a bit of an urgent problem.
Yeah,
we got there.
I tell you what, if I ever find myself with a hole in my foot, I'm coming north of the border, pal. I'll come and see you. Thank you, Adam.
No worries.
Any other questions for Adam at this point? Oh, Giacomo is asking, hi Giacomo, how many laser treatments per week did you apply on that last case, and how many treatments in total?
2 per week. In total, I do have her notes next to me, so I can tell you. She's now got like 200 odd appointments because we keep her coming back. Just keep it on top of it. Initially, it taken around about that first sort of 6 to 8 weeks to get the closure twice per week, and then just because I was a bit worried it was a bit soft underneath, we just kept doing the laser for a further few weeks just to ensure that there was no breakdown. The main thing was trying to get offloading and trying to tell her, please do not run on this, please do not jump on this, please do not do all these things. So yeah, so
twice a week for 6 to 8 weeks was your initial treatment.
That was the initial.
And then once a week for your maintenance after that. Perfect, thank you. We have got Jill from Sydney. I was saying we had people from Australia registered, and well done, Jill. It must be late with you. She's wondering if the laser was used more frequently post PNA, if the results could be even better considering that it's an acute wound. She's also had excellent results with chronic stagnant vascular ulcers on lower legs as well. MLS will be my go-to for all wounds from here on out. So I guess it's hypothetical and tricky to answer, but if we use the laser more than twice a week on these acute wounds, I guess we could well get potentially quicker results. Yeah, we did find that there was a few of the people who I was checking the notes were in weekly, and that's probably what brought the figure down for group 3, where they were a bit shorter in time, so it was weekly, and that tended to be, it was somebody who was such as, we had a few sporty people trying to get ready for football season and things. So yeah, but we do occasionally do shorter appointments. It's just at the time our protocol was pretty set. We're a bit more flexible now. I like flexibility. Yeah, it's making it work for the availability that you've got in the clinic, how often your patients can come in, and finding that balance between getting them better more quickly, but also making it manageable for busy people and busy podiatrists. And it's nice that you can do that with the laser as well. You do have that bit of flexibility. Anybody have any more questions? 10:30 p.m. with Jill. It's dedication. That's perfect. So I'll let you all go and grab a cup of tea before you go back to work, or in Jill's case, to bed. So thanks very much, everybody, for coming along. If any questions do pop into your head after the event, you've got Adam's email address. You can drop a message to Celtic as well, to myself directly, kSinclair@celticsmr.co.uk, or ping us an email through the website and we'll get back to you. You can see the full range of MLS lasers that we supply on our website, which is celticsmr.co.uk. Portable and robotic lasers, information on there, or contact us for more information, or just even for an informal chat. If you're interested about laser, interested to know more about laser and you don't have one already, then we're more than willing to have a chat about what it can do and how you can integrate it into your practice. Thanks everybody, and thanks Adam. Thank you very much, appreciate that. Superstar as always, excellent presentation, very well organised. So we will see you all for our webinar next month, which is on the topic of laser as part of a treatment plan, and that's with Olga Jones from Pure Movement Clinic. And nice to see Giacomo and Cinzia from ASA here as well. Thanks for coming along. Bye.